important educational supplement for fellows and residents. These sessions are really meant to bring together the neurotology community's collective expertise and also serve as a resource for residents interested in neurotology and neurotology fellows. We hope that it sparks discussion. So if there's any questions that come up along the way, feel free to put it in the chat or stop any of us. We'll get started now. Today, joining us is Dr. Douglas Mattox from Emory University, who will be leading a discussion on pulsatile tinnitus. Dr. Mattox is a Hugo Fish trained neurotologist and the current chair at Emory, who's been leading the department there for almost 25 years. Very lucky to have this opportunity and so grateful that you're with us, Dr. Mattox. So with that, I'll turn it over to you to share your screen. And just as a reminder, if everyone could keep themselves on mute unless they have a question. Thanks.
Thank you so much, Mallory. And as is typical of you, you're always organizing everyone and everything. And I appreciate your efforts and certainly appreciate the invitation to join this group for the kickoff here. So let me see if let's see, here we go. Do you have my slides there? Wonderful, it worked. Okay, so Mallory asked me to talk about our experience with sort of a variety of interrelated conditions of IIH and various somatosounds and what we've done with pulsatile tinnitus. So we will jump in here. Let's see, return, how do I advance here now? There it goes. So somatosounds are those sounds generated by structures adjacent to the ear, most of which are vascular, but we talk about the TMJ, the eustachian tube. People frequently complain of clicking that I think is their eustachian tube opening and closing. Occasionally we'll get sounds from spasm of the stapedius and tensor muscles. And of course, cerebral pulsations, particularly with superior canal dehiscence, as we were just talking to. And I just want to, I hate this distinction between subjective and objective tinnitus, because objective, I think, depends on how fastidious you are in trying to hear the sound. So are you just in the same room with the patient, or are you actually in an audio booth with a stethoscope trying to hear it? So I like the differentiate between sort of sensorineural ringing tinnitus versus somatosounds. And Pat Hudgens and I put together an algorithm years ago now, and we defined somatosounds in sort of three groups: whooshing, which we'll get to at the end of the talk, rapid clicking, and then the autophony symptoms. So we're going to start here in the middle with rapid clicking, and that's generally attributable to palatal myoclonus. And it's a repetitive clicking heard in one or both ears, generated by the tensor vela palatina or the tensor tympani. And I think the sound is probably generated by the eustachian tube opening and closing. It's sometimes inhibited by opening the mouth. So if you have any chance of seeing anything, it's going to be with nasal endoscopy, slipping into the nose and looking at the upper surface of the palate and the pharyngeal muscles. And this is a lady, a patient that I had, and you can see her palate. And she's kind of a funny lady. She related this story when she was at the grocery store. The man behind her said, I hear a clicking. Do you hear a clicking? Oh, it's you. And so this was an audible to an observer. And What's important about this syndrome that you need to remember is that this can be related to brainstem abnormalities, AVMs and whatnot. And so anyone with this spectrum of symptoms needs to be worked up with an MRI. And how to manage it. I've had a few patients that I've done transnasal Botox into the peritubal muscles with some benefit. Others have suggested cutting the tensor tympani tendon. It's really easy to do, and in my experience, it rarely helps. And I think that's because the sound is really coming from the eustachian tube down here, opening and closing, rather than the spasm of the tympanic membrane itself. So let's talk a little bit about IIH, because it's going to relate to so many of the things that we talk about today. Elevated intracranial pressure, unknown etiology, other than there's clearly a relationship with truncal obesity. And I'll show you some slides. In the last couple decades, there's been a huge increase in the number of shunts that have been put on, and a high degree of these individuals go on disability. The only real risk factor is truncal obesity, which is a major risk factor, probably related to decreased venous flow through partially compressed cervical venous return. Most common symptom is headache. They can get visual changes, and pulsatile tinnitus is seen in half of the patients. You can see papilledema, visual field defects. Interestingly, the CSF composition is entirely normal, and by definition, above 28 centimeters of water, CSF pressure on supine or lateral lumbar puncture is a commonly accepted definition. And imaging does not definitively define IIH, but there are lots of suggestive symptoms, including empty sella. The posterior globe can flatten because there's a subarachnoid space that runs along the optic nerve, and so you can see that distension on MRI, and it can even cause some flattening of the globe. Transverse sinus stenosis is a very, very common finding in these patients. And on either MRI or CT, you frequently see thinning of the skull base, widening of the foramen with probable meningoceles and or encephaloceles. And here's a typical sagittal MRI scan. And do you see the pointer, Mallory? Do you see my pointer? No? Okay. You see the sella there with the pituitary gland plastered posterior and inferiorly, and CSF space filling the sella. CSF secretion is controlled by cortisone reductase, the HSD1, and in the choroid plexus, and it's inhibited by a low-calorie diet, and of course increased in a high-calorie diet. Also, you can see anatomic narrowing obstruction of venous sinuses by arachnoid granulation. We see those at surgery. And the risk is almost linear with increasing BMA. So let's turn now to the anatomy of the middle fossa. I think this is probably very familiar to everyone on this call today. But you have the petrous ridge defined by the superior um, petrosal sinus, with the semicircular canals behind and the cochlea in front of the facial nerve transecting the two, sigmoid sinus posteriorly. And a common sequelae of increased intracranial pressure are encephaloceles, and you can see on the left a small spontaneous encephalocele hanging down, touching the tip of the head of the malleus. And on the right, a post-surgical complication of an encephalocele coming down into a mastoid cavity that probably had too much bone removed during a mastoidectomy. Repair of these lesions can be done a number of different ways. You can go through the mastoid and elevate the encephalocele or transect the encephalocele. But my preferred approach is to go through the middle fossa with a small little craniotomy. And there are times when you want to combine the two to be able to look a little easier into the middle ear, as well as through the middle fossa. And I use either temporalis fascia, or I'll show you a little mastoid periosteal flap that I frequently use. Or more recently, I've been using more of the biodesign Duragraft material that you just take out of the box and lay in there. And I generally use a little bone graft, which is usually part of the craniotomy flap. And ultimately, if none of those are successful, you can always do a petrosectomy with closure of the ear canal and obliteration of the eustachian tube if there's no other alternative and you're willing to sacrifice conductive hearing. So this just shows a picture of the mastoid periosteal flap. So instead of making the sort of typical T-shaped incision in the mastoid periosteum, I'll raise this superiorly based flap pedicled on the temporalis muscle, and that can tuck down into the middle fossa quite nicely to give a nice vascularized flap. So here's a view through the middle fossa. This is the right ear. The temporal lobe is being retracted, and you can see the defect in the floor of the middle fossa and the brain tissue. Someone could mute. I hear a little bit of rattling around. Thank you. You can see this delivers out of a small orifice. It's interesting how much brain can ooze through a tiny opening in the dura. It's like toothpaste with a hole in the side of the tube, and just squeezes out. And you want to clean this out of the middle ear as much as you can, or else you may be left with a conductive hearing loss because of the scarred tissue all around. And, you know, it's a gift that keeps on giving here. And I think we're about to the rest of that, yeah. And I think once we get this out, let me jump ahead just a little bit. There it comes. We'll be able to see the ossicles. There, now I hope that, yeah, now you can see the tip of the malleus there in that defect. So now we've got, you know, a 1.25 centimeter or so defect, and so we'll take a piece of the craniotomy flap and place it in there, and then we'll rotate that mastoid pericranial flap based on the temporalis muscle like vascularized tissue to heal and stop any CSF leak. And this is a different case, but combined transmastoid middle fossa. This is a left ear. We're looking up at the bone graft from below through the mastoid. And the floor of the middle fossa, as you all know, is very irregular, so it's hard to get a perfect fit. But you like to have it fit as smoothly as possible. Well, we had a look years ago. One of our former residents, who's now a faculty member out in California, looked at our encephaloceles and CSF leaks, and she divided these patients into two groups, those that were spontaneous and those that had an identifiable cause from inflammation or iatrogenic injury and so forth. And at that time, this was a somewhat novel finding that the BMI was higher in the spontaneous group than in those that had an identifiable cause. I think that's pretty common knowledge for everyone now at this point. And we alluded a minute ago to craniotomy for CSF leaks, and over the past decade, and it's increasing. So let's switch gears a little bit and talk about the next realm of somatosounds, and that being autophony. That is, people who have a distortion hearing their own breathing. And for me, the next, or hearing their own voice, I'm sorry. And for me, the next important question is, do you also hear your own breathing? And if they do, that's going to make me think about patulous eustachian tube as the most likely etiology. Whereas if they don't, I'm going to think much more of superior semicircular canal dehiscence. It's not a perfect differentiator, but it certainly gets you to the next step. And just a word about patulous eustachian, because it can really be disturbing to people. When the eustachian tube is permanently open, you hear your own voice and your own breathing transmitted directly up the eustachian tube into the middle ear, where it vibrates the undersurface of the eardrum and can really cause very annoying symptoms to patients. It's often better when people are supine, because I think the eustachian tube collapses a little bit and often increases with exercise. This is a symptom. Sometimes people will tell you about the autophony straight away. Their complaint is pressure and fullness in the ear with an otherwise normal examination. And we see so much pressure and fullness, and you think, oh, this is just another one of those, and I'm not going to see anything. But it's worth taking 10 seconds and just asking about the autophony and breathing symptoms in these patients. Sometimes you can see fluctuations in the drum when the patient sniffs or breathes. And if you've got a clever audiologist, they can often record the movement of the tympanic membrane with tympanogram with breathing. Management, I think this is rarely helped with a myringotomy, but virtually everyone you see will have had one. I never put in a tube unless I do a myringotomy. I send them out to the waiting room for 20 minutes. If they're really genuinely better, I'll put the tube in. Otherwise, I'll just let the myringotomy heal. They all come in on nasal steroids, which is the wrong thing. There have been various treatments proposed to try to induce edema or swelling of the eustachian tube, including acetic acid drops, Premarin drops, and various grafts and cautery to partially obliterate the eustachian tube, which I haven't had to do in a long time, but have had quite a few patients over the years. Now, on the other side of that coin are patients with superior semicircular canal dehiscence, first described by Lloyd Minor 2 decades ago now. And you all know the orientation of the semicircular canals. And the superior canal is particularly vulnerable to either loss of bone, reabsorption of bone, or congenital absence of bone, so that pulsations in the cerebral cavity are transmitted to the inner ear. SSD has a number of different symptoms. They can complain of pulsatile tinnitus, autophony, various somatic noises from bone conduction hyperacusis, including their eye blinking, their footsteps. They may have vestibular disturbances from either sound or pressure in the ear. And as I said, they generally don't complain of hearing their own breathing. And the fascinating part of this syndrome is that patients with identical radiologic findings can have vastly different a set of symptoms, including the most common symptom, which is no symptom. And we see the radiologic findings in people with no symptoms at all as an incidental finding quite frequently. So they can have vertigo or nystagmus in the plane of the superior canal, low frequency conductive hearing loss mimicking otosclerosis, supernormal bone conduction hyperacusis. They have decreased thresholds on cervical vent. That's just another sign of the bone conduction hyperacusis. And of course, imaging is the definitive thing. So here's a typical otosclerosis audiogram, but you see the patient has reflexes. And I always get the audiologist to do reflexes. They say conductive hearing loss. I don't need to do reflexes today. But you run the risk of trying to do a stapedotomy in someone with a different problem if they don't do that. So here is a normal canal. We're going from anterior to posterior, left to right, and you can see these are coronal CTs with intact superior canal all the way back. And here is a similar finding. And in the second image from the left, you can see the canal looks truncated. And in the second from the right, it's only a tiny little notch. And then on the right, it starts to be reconstituted in a similar picture, most dramatic in the third cut from the left. You can see the canal as only a notch. And of course, if your radiologist is really clever, they can do beautiful recons showing the dehiscence in the superior canal. So there are different approaches to solve this problem, either through the middle fossa or occasionally through the mastoid. And it depends a little bit where the fistula is. And if it's right up on top, as shown in the lower cartoon here, then I think the middle fossa is ideal. Some of them are sort of low and back posterior around the corner, and I think those may be better approached through the mastoid. When you surgically approach the mastoid, you have to obliterate both anterior and posterior to the defect, whereas through the middle fossa, you can easily see the defect and block it off. And I use a preauricular incision sitting at the top of the table, small craniotomy. And here is a fistula right here. I don't use the retractor anymore, but you can see the fistula in the superior semicircular canal, and I think I've got a little bit of video. Right there is the fistula. I use a combination of packing it with bone dust that I harvest during the craniotomy, and then I put a layer of Hydrocet over the top. So we can jump ahead here a little bit, and you can see just using a respiratory to start packing in some of that bone dust. Then I think, let's see, this just shows more of the packing, but I do that fairly vigorously to, and then here is just putting some Hydrocet over the defect as well. And if you've got a middle fossa retractor, as in this case, you just want to make sure you don't glue your retractor in with the Hydrocet. Etiology of this is not quite understood. Some people have proposed it's a congenital defect, and then as the dura thins with age, people become symptomatic. Others have thought that there's thinning of the bone and loss of bone. We don't have any 20-year studies to see if the bone really changes with time. These patients are generally not the IIH body habitus, but I'm sure that increased intracranial pressure plays a role. A couple of years ago, one of our then med students, now residents, Melissa O, looked at our concordance of superior canal dehiscence and CSF and encephaloceles. And to cut to the chase, we had 92 study subjects. She used 100 controls, which were people that were having mastoidectomies or temporal bone studies for other reasons. Of the patients with both an encephalocele and CSF otorrhea, 16 of 52 also had radiologic evidence of superior canal dehiscence. When she looked at either encephalocele or CSF, it was 11 and 17%, and if it was either or, it was 24% of patients also had superior canal dehiscence by radiology, and in the controls, it was 3%. So clearly some relation relationship. And I think where this is important is, I had one case several years ago where a patient had an encephalocele. I knew from imaging that she did have a superior canal dehiscence, but I still managed to get a severe hearing loss from repair of the encephalocele. So I think this is something you always need to look at very carefully and exert all caution in the area of the superior canal. This is just bar graphs showing the same thing. So let's change horses now and talk a little bit about vascular tinnitus. And my interest has been in these vascular bruits coincident with heartbeat. The differential of neoplasms we're not going to get into today, but I think what's important are venous bruits, sigmoid diverticulum, and sigmoid dehiscence, and transverse sinus stenosis. So just to reiterate the anatomy here, you know, the arterial system is only 1 to 2 millimeters from cochlea at the first genu of the carotid, and you know the vascular anatomy around the temporal bone. Vascular bruits have their own website, whooshers.com, and like every other disease. I think that's what's really important here for me is obviously we're going to do an otoscopic exam to look for tumors. We're going to listen to the neck. And I do that in an audio booth. Just because our rooms are so noisy. And I think really important is whether you can change the pulsatile tinnitus with supravenous cervical compression, just in the area of the jugular digastric node. A lot of patients will come in telling you when they walk in that they can do that. But that really helps me think about, is this going to be an arterial issue or venous issue? And if I think it's arterial, particularly in an older individual, I'm going to go straight to a carotid ultrasound. If I think it's venous, I think the anatomy is much better demonstrated with a CTA. And we have a special protocol where we get a CTA and a good temporal bone study. Generally, the bone windows on a CTA are terrible. So we do a combined study, and that can differentiate all kinds of anatomic things around the temporal bone. If the CTA is negative or the ultrasound is negative, you can consider an angiogram to see if there's some sort of dural AVM or AV fistula. But generally, the CTA answers our question. So we do, Pat Hutchins came up with a protocol a number of years ago that we still use. We do a venous injection with a delay, so we see both the venous and the arterial side. So we've seen a number of carotid abnormalities, a lot of atherosclerotic disease, and had a few cases where the stenosis was contralateral to the subjective tinnitus, and an endarterectomy relieved the pulsatile tinnitus on the opposite side. So it doesn't have to be on the same side. We've also seen several carotid dissections without a history of trauma, and AV malformations, cavernous fistula. So here's an interesting axial CT scan, and I hope some of you can see why this young lady had pulsatile tinnitus, if you look at the two middle images, you can see the carotid has eroded right into the basal turn of the cochlea. So I elected to leave her with her pulsatile tinnitus rather than trying to mobilize the carotid. I thought I'd probably kill the ear in the process if I didn't kill the patient. So, but you can see this is a nice demonstration of the CTA. You can see contrast in the sigmoid sinus and contrast in the carotid. So it gives us very, very pretty pictures. So venous abnormalities start with what we've known for a long time, dehiscent jugular bulb, and if that pooches out enough to touch the tympanic membrane, then you're going to have pulsatile tinnitus. Unknown significance here, but one of the things we found was thrombosed condylar artery seen at the right-hand arrow versus contrast in the on the left side. Unknown significance, whether it was related or not. So almost 2 decades ago now, I had a gentleman come in with right-sided pulsatile tinnitus that he could extinguish with pressure in the upper neck. And he was involved in professional societies, and he'd sit in conferences all day with his finger on his right neck. And we got a CTA, and lo and behold, here is a sigmoid sinus with a diverticulum coming off the side of it and almost eroding through the lateral cortex of the mastoid. Shortly thereafter, we saw another lady with actually something on both sides. And here's another small one. And another one. And so we started seeing these, I didn't want to call them aneurysms, so I called them diverticula right at the junction of the transverse and sigmoid sinus. And so we published a number of years ago our first experience with surgical management of these by skeletonizing the diverticulum and reconstruction of the sigmoid sinus to try to provide a smooth wall without turbulence, because I think what people are hearing is the turbulent flow, and of course these erode into air cells, so you've got an air transmission, sound transmission passage through the mastoid to the middle ear. So here was this lady just after raising the periosteum. No drilling has been done at that point. And here is the diverticulum, sort of the preliminary dissection, still a cover of bone around it. So I'll show you a couple of videos. This was a huge diverticulum a huge sigmoid sinus with very small diverticulum on the anterior surface. And I was reluctant when I saw her first to do anything, because you see her opposite side is so diminutive. And I was a little bit afraid to do anything to her. But she came back 9 months later, and I think I can convince you through these serial scans that this has gotten a little bit bigger over that interval. And here it's quite easily seen on the right side. So here were the intraoperative pictures, shows exposing the diverticulum and then reducing it. And at that point, I was just oversewing with a little piece of muscle to reduce that diverticulum. Here was a huge diverticulum, you can see here. And this one, again, no drilling has been done, and this is all diverticulum having eroded through the lateral cortex. And here it is in the initial exposure. And I'll show you just a couple of videos here of starting to expose this. And I just try to get the bone really thin. These are really thin-walled structures. But I think it's important to get a thorough exposure and thorough reduction because we want that smooth, non-turbulent flow in the sigmoid. So, and this shows starting to, oh shoot, you're kidding me. Okay, great. So this shows peeling off that last little layer of bone. And just in case you don't think there's blood in that, I'll prove it to you here in just a minute. There you go. So, and the next slide is interesting to me because you know how when you do a neck dissection, you can see little bubbles of nitrous oxide in the jugular vein. And oh, here I have to go through this same rigmarole here. Fortunately, it knows where it is. And so I think you can see fairly clearly the turbulent flow in that sigmoid. So this was clearly bigger than anything that I could oversew. And so what we did was we took a large muscle flap and then just used a titanium plate bent to the appropriate size, shape to hold that sinus in reduction. More recently, we've been using hydroset rather than the plates. I'm going to skip through this one for it shows a similar thing. So this was our initial report, and all of them had reduced and 7 were completely gone. We had one late recurrence that we did a revision on with success. So I guess the skeptics among you say, well, you probably have just thrombosed the vein rather than reduced it. And that's what cured the pulsatile tinnitus. So here's a post-op CTA. You can see there's contrast in the sigmoid on the right side. And here, well, it's not showing. Actually, it is. This is the lady that had that very large one. That you can see, again, contrast in the sigmoid sinus in the post-op imaging. So I think we actually have done our goal of reconstructing the sigmoid rather than just thrombosing it. So we looked at our cases a few years ago now, and the numbers are not important, but I think the ratios are interesting. So about 40% of our pulsatile tinnitus cases turned out to be venous, 25% arterial. We found 1 canal dehiscence. And there's a significant number of patients that we never find the cause. And that's a point of frustration. Even those that of those when we take them for 3 or 4 vessel arteriogram, we don't necessarily find the cause. So I always warn patients up front that that you may well that we may well not find the answer. Now, 10 years ago, Mike Eisenman at Maryland reported improvement in resurfacing the sigmoid in patients with sigmoid dehiscence without an actual diverticulum. And he was absolutely spot on. Here's a patient with very thin to absent bone over the sigmoid. This is not a surgical defect. This is what we found when we exposed the sigmoid. And for those patients, it's been gratifying just to cover the whole thing with a network of Hydroset and it's been very gratifying to eliminate their tinnitus. Other people have had similar difficulty finding arriving at diagnosis in that last 25% of patients. And as I said, even those when we did 4-vessel arteriography, we didn't always find a cause. Sigmoid abnormalities are clearly related to intracranial hypertension. The vast majority of these cases are middle-aged, obese women, although there are a fair number of men as well. You can see here's the distribution of BMI in a recent studies. And we've had been fortunate in not having any major otologic or neurologic complications in this series. So, you know, what's next? I think that IIH, clearly in association with CSF leak and encephaloceles. I do lumbar punctures after we've repaired them. I think when they're still leaking, they're releasing the pressure, and there's no value in doing the diagnostic LP ahead of time. We get all these folks seen by neuro-ophthalmology. And we try to get them into the bariatric center. That's a frustrating experience or disappointing experience. And although we've not delved into it, there are a significant number of these patients that you'll get back a reading of stenosis of the transverse sinus. There's growing literature about stenting of the transverse sinus, and I think that's probably the next chapter in this story. So, in summary, there are multiple associations, otologic associations, manifestations of IIH. I think it's important to try to understand whether these patients have arterial or venous vascular tinnitus. CTA is our imaging technique of choice, and keep looking because there's still things to be found and understood. So, thank you very much. Happy to entertain questions or disagreements or discussion. Let's see here. Maybe is that unshare? Yeah.
Doug, thanks for
Dr.
doing this.
Anyone should feel free to ask questions. I've got a couple. Dr. Mattox, these are just some patients that we've seen throughout the year. Hopefully might spark some discussion. But in regards to palatal myoclonus, we saw a patient earlier this year, middle-aged woman, otherwise healthy, who had a rapid clicking that was unilateral, lasted for a couple minutes at most. Really non-specific physical exam findings. So normal nasal endoscopy, normal palate exam, but presumed to be tensor in origin. Tried on muscle relaxants for a period of time, tried a second one, no significant improvement. So offered tensor speedius lysis and did that, and she did well for a period of time, completely resolved, and then after a couple of months returned. I know that your slide had kind of recommended against that it wasn't always successful, but in that situation, would you move towards Botox? Would you move towards re-exploration based on her initial improvement?
And what was, I'm sorry, what was the initial intervention?
Tensor and speedius lysis.
Yeah, yeah, that's been my experience, that that it doesn't, that's not where the problem is. If you get an old-fashioned tonsil needle, that thick needle with a little sharp needle at the tip of it, you can slide that transnasally and try a few units of Botox in the peritubal muscles and see if that helps. You have to warn them, if you get too much, they'll come back talking like this for 3 months. But I've never had that happen. But it's a difficult problem.
Yeah.
Dr. Mattox, thank you for doing this, and Mallory, thanks a lot for organizing. This is Eric Formeister, one of the Hopkins Fellows. I actually just saw a patient who also probably had tensor tympani spasm, and I was surprised to see that there really isn't too much written about this, but I was curious, when you're trying to medically manage this first, what is your go-to for muscle relaxants? Do you do baclofen or Flexeril, or what has your experience been with medical management of it?
I would say that I don't really have any experience with medical management. I just, giving a systemic drug for such a localized, I don't know. I haven't tried it maybe but a time or two.
Okay, thanks.
I think there's a great thing called tincture of thyme that works pretty well for a lot of that myoclonus. Not all of it, but a lot.
Yeah, yeah.
Doug, I didn't hear you mention Diamox. Do you use that at all in any of your patients, CSF leak or pulsatile tinnitus patients?
We do. I'll use it in the perioperative period after CSF repair, just to try to reduce the pressure a little bit and let things heal. I try to talk them into doing an LP, 6 weeks later or something like that, and if there are signs, or certainly if the neuro-ophthalmologist sees signs, but usually their evaluation is negative. I have to say, we've had very few come back with positive findings.
In the population of likely IIH patients, elevated BMI, who have multiple findings that could explain a unilateral pulsatile tinnitus, such as those who might have a sigmoid sinus dehiscence and what looks like a Tegman dehiscence, perhaps something touching the oscles, but no CSF leak, at least by exam, and SSCD. Complaint is pulsatile tinnitus. How do you think about management, addressing the IIH systemically first and then looking towards surgery or another route?
Well, as Paul mentioned, you certainly can try them on a trial of Diamox to see, if that's of any benefit. don't know that I've had one or two patients that had both a superior canal dehiscence and a sigmoid dehiscence, and it's hard to know which is the is a culprit. I think if they were really sensitive to venous compression, then I'd try the sigmoid reconstruction first. I think that's I think the attendant risks are less, and so if I really was unsure, I'd probably start there. If the venous compression did nothing, then I'd probably go toward the superior canal first.
Okay, makes sense. Well, Dr. Mattox, if anyone doesn't have any other questions, we'll kind of call it there. Thanks so much for joining and agreeing. This was great. Set the bar high for continuing. And we're just really fortunate to have you be able to talk to us.
Thank you very much for organizing, Mallory. That's clearly one of your many fortes, and I'm glad to participate. Thank you for the invitation.
Thanks, Ken. To everybody else, first and third Mondays, 5 p.m. Eastern time, and you can look at the recording if you want to on YouTube. We'll call it there. Take care, everyone.
Bye-bye.